Hello there, and welcome to the NASGP's podcast, The Art of GP Locum. And today I'm delighted to be joined by Dr. Kalindi Tumurugoti, who has a wonderful spread on his CV of organisations that he represents and actively supports. And Kalindi and I have met over the years, particularly with Kalindi's role in Nottinghamshire LMC, which I'm sure Kalindi will be telling us about. But also, more recently, we've got to be talking as an organisation to BAPIO, the British Association of Physicians of Indian Origin. And Kalindi will be talking about that, and I'll be asking Kalindi about that and his other roles. So, Kalindi, welcome to the podcast. Thanks very much for coming along today.
Hi, Richard. Morning. Thanks for having me. I'm delighted to be a part of the podcast too.
Great, thank you. So I suppose kicking off really, I know that you qualified as a GP in 2013, and I'd love to hear about your career journey that got you from qualifying as a doctor to becoming to starting your GP training, and then what you did from your GP training after that. But I understand also that you actually, before you even started as a GP, you had already joined BAPIO, hadn't you?
Yes, indeed. Yeah. I obviously, I'm an international medical graduate, Richard. As you know, I came to UK in 2003 and then obviously started in various hospital specialties, predominantly surgical specialties, followed by emergency medicine. But that's when I got introduced myself to BAPIO in, I think, 2007, where I've been actively part of the organization. And I think there was a big, if you may remember, there was a big court case. BAPIO has taken the Home Office with regards to a sort of a rule where people were not given permanent residency, and then the BAPIO won it, along with a forum called HSMP Forum. So it's quite a long association with me and BAPIO.
Very much. And so you were in hospital medicine at that stage. What country had you? Where had you qualified from? Where was your medical school?
My medical school is from India. I qualified in India in 2000, and then I came over here in 2003.
So you've been working as a doctor for three years in India, and then it took then about 4 years to sort of for you to find BAPIO. So what was it about BAPIO that made you want to join at that stage?
I think if you look at activism, and it all starts with one aspect, be it, say, for example, a rota issue you are leading in a hospital, or be it something else that's affecting you and friends and colleagues around you. So there was an issue about Home Office has changed the rule from 4 years to 5 years in terms of eligibility for permanent residency, and then they applied it retrospectively rather than prospectively. And then that's when there was a big online forum, and then I got involved with the BAPIO, and then I attended one or two seminars and educational events and got to know the great work they were doing.
So and that's obviously when you then joined BAPIO, and you were there just as a regular member, were you then at that stage?
I was there as a regular member, being actively, there was another online forum, there were AHU groups at the time, and then we were actively engaging through that forum, and then discussing a lot of issues pertaining predominantly to BAPIO members and international medical graduates at the time. And then in 2010, I think, we got together, three of us, through the BAPIO, and we discussed setting up an organization to support international medical graduates in terms of their medical legal problems.
Right.
And that's where what we call Medical Defense Shield, MDS, has born.
Right. So to explain what MDS is then.
MDS is in collaboration with BAPIO, it was set up, I think, around about 2010 onwards. Obviously, it has grown. It's akin to your MDO, Medical Defense Organization.
Okay.
Plus, it supports employment support as well as like a one-to-one. Say, for example, if you're involved in a performance investigation or something, they can send you a representative to be with you.
Okay, so it's
Uh,
not just medical defence, it's also sort of almost like a trade union almost, would that be right?
well, it's not exactly trade union. It's
No.
like a personal support,
Got
as I would say, like any sort of if you're appealing against a decision with a deanery,
I've got you.
there is some second person is there just to go through and put a second hand, just be next to you if needed.
That's interesting. So that's so it's that they're supporting you both in terms of your clinical clinical
The,
risk, but also in also your workplace
yes, and
set
that's
of
where it is
issues.
unique, and that was the idea. Like for example, as well as providing the medical indemnity cover, um, it provides the support. But over the years, it has evolved quite a bit. And then if you look at the website, it tells you all about what it does at the moment.
And is that a main reason for people joining BAPIO? Do you think, or are there other reasons why they
There are many
want to join?
reasons. I think it provides a bit of a forum for like-minded people, and I think BAPIO does a lot of work. It regularly engages with like for example, from a GP point of view, RCGP, it engages with RCGP all the time in terms of exams and what sort of problems especially BAPIO members and IMGs face through the exams, and then it engages with the GMC on a regular basis, any sort of its important stakeholder in terms of issues affecting IMGs. And now it has got a nursing arm as well as a health research, BAPIO Institute of Health Research, and also a BAPIO Faculty of Leadership as well, where you can get peer support. And then if you're interested in, say, for example, writing a journal and submitting it, people can help you with that.
So I'm wondering if there are two things there. Then one, firstly, it sounds like by the rate at which you sound, the organisation has added all these extra strings to its bow, as it were. It also must be therefore quite good at listening to its membership if it's responding by adding these extra resources for its members, but also speaking at high level to organisations like the Royal College.
Yes, yes. I mean, it depends on the on so what is affecting at a particular point in time the BAPIO members, and it also engages with Indian High Commissions if needed locally. Say, for example, if you're stuck, something happening, or your parents are here, something happened, they have got the goodwill. The BAPIO has goodwill among us, and they can sort of facilitate some quick issues like emergency visas and repatriation, those kind of things. And then it has set up a big organization called GAPIO. It's called Global Association of Physicians of Indian Origin.
Right.
And it's growing. Obviously, it's massive. And both BAPIO and GAPIO have conferences every year. Here, sometimes GAPIO conferences were across the globe.
So, if you are an overseas graduate working in the UK, but you're not didn't actually graduate in India, does BAPIO is BAPIO still have its doors open for membership?
Well, yeah, of course it does. It started as a sort of helping overseas graduate, but it is now open to anyone and everyone, irrespective of their origins. Obviously, you can see the website if you the ethos and everything. As I said, there's a lot of local support as well. BAPIO divisions are really active. Some local divisions are they're doing a lot of great work, CPDs and etc. And then if you look at it, within the membership, there are different forums. For example, GP Forum is there, which I'm chairing, which is still evolving
Good, yeah.
as we speak. And through the GP Forum in BAPIO, um, Richard, we have engaged quite a lot with CQC. We've done some survey affecting our members and sort of engaged in discussions with the CQC and other stakeholders, for example. And then there's Young Doctors Forum, where obviously students and newly qualified people, irrespective of the specialty,
Right.
get together. They have their annual conference. And there is technological forum now, I think, and then robotics and AI forum. Obviously,
Wow.
these are evolving as we speak. Like if you're interested in AI, you can join the forum and then be part of that. Obviously, it all depends on what you do wisely with your 24 hours, isn't it?
Yes, yes. And you mentioned a lot of online forums there, but it also sounds like you also have in-person events as well.
Yeah, BAPIO conference is in-person event. Mainly, it's annual conference. The last time it was in Bristol. I think can't remember where it's going to be. The divisions have a lot of in-person events, local divisions. We, as a GP forum, haven't had a chance to have had a sort of face-to-face event yet.
Oh, you've got to change that. You've got to change that.
As you can imagine, there's a lot of logistics, isn't it? Face-to-face,
yeah,
it's not
very much
easy.
so.
We've just, obviously, we're coming out of, well, almost come out of pandemic now. People are meeting face-to-face. Yeah, that's on the card, certainly.
Do you think, just as a side note, do you think as in general practice we are slower coming together for in-person events than our hospital colleagues are, if you've got your foot in both camps, as it were?
Yeah, that's a very interesting question, Richard. I think it seems like I've been a partner, I've been a locum and salaried GP. It feels like whatever type of work you do as a GP, you are a little bit lonely, I think.
Yeah.
And something is happening to general practice after pandemic. If you look at it, there was an article in BMJ how pandemic has affected general practice more than any other specialty. So I think we're all swarmed, aren't we? Whatever you are, and then as you can imagine, work is supposed to be a third of your life. You got 2/3 of your own life to you, actually, yourself. So that's, I think, it's a sad state of reality. And then it seems like there is some recognition at the moment by the powers that be, saying that, oh, we put money into community, but we just need to see how much of that words turn into action.
Yeah, it has to translate, doesn't it? I've been going to a few events with NASGP and Locum Deck, and I've been in Bristol recently, and Birmingham and London and Leeds, and at various events, and it's quite tangible. I think the difference between the newly qualified GPs who have recently come out of hospital, and still got their feet almost in both camps, as it were. And I do find that particularly most recently the Bristol one, when it was just purely GPs in training, they just seemed so energetic and so energized, and there was so much enthusiasm and buzz. Whereas I think maybe GPs like us, but also a third of our working lives. I think a lot of GPs thinks it's 50% of their work, of their lives are at work. I think it's just a lot of them who just seem very exhausted, but I always find that in-person events are just more energizing. I come away with my batteries charged. Although a lot of these online events, I'm just finding they're just a bit draining. So it's interesting, isn't it?
Absolutely, I completely agree. I think that if you see someone face to face, because as a human being, you are designed to interact. You are a social animal, and especially during medical training and medical school, you are designed to you are trying to sort of see face to face. I think partly because I think if you look at it, the good thing that happened with the pandemic for GPs, excuse me, is that appraisal has changed.
Yes.
The mandatory.
Shush! Don't say too much. It's quite nice like that.
It is quite nice.
Yeah.
I think that's probably a little bit demotivating factor. Maybe like you don't need to there. And then the other thing is this is obvious, isn't it? Pandemic has taught us how to use Teams. I never heard about Teams before pandemic. Honestly, I never knew that kind of. I heard about Zoom, but never heard about Teams. And then now look at it. We use Teams and Zooms like they're part and parcel of our life.
Yeah, and they're so dull. It's so dull, isn't it? I really enjoy being at these events and actually standing with a plate in your hand, talking to other people, and actually being in a group of people actually eating together. And that's quite. I'm so unused to that, and I found that quite a thing
Well,
to get used to again.
yeah, couldn't agree more. It's more energizing, and it just there are certain things you can do, the body language, everything. You can't just do the face. And also remember, any day jobbing GP will have spent 90% of his working life in front of a screen, and then to come
Yeah.
home and sit another hour and a half in front of screen just doesn't
No.
appease. Like it doesn't feel like it doesn't motivate people. And
No.
if there is a food and face-to-face event, it's a switch off thing, isn't it? You don't look at the screens and then you can interact with the people.
That's right. That's right. And there's no these disturbances of kids running around, or the dog coming in, or the plants need watering, or an email. But yes, you don't have
Of
those.
course, yeah.
So, so you qualified as a GP in 2013.
That's
Then,
right.
so it's 12, 13 years ago. So what made you change then from your hospital surgical type roles and A&E to go into general practice? What piqued your interest in general practice then?
Good question. I think life goes in circles sometimes.
It
I
does.
was in ED. I started as a surgical specialty and jumped to ED when the modernizing medical careers came in. We call it medical training initiative,
Yeah.
and then I was doing ITU, CT2 ACCS job, and then I got CT3, and then obviously you got to go 4 more years in ED training. I started doing ED from first job as a middle grade in ED was in 2007. So I liked the ED bit, but the ED from then to like for example 2009 2010 evolved. A lot of EDs have taken observation wards. It used to be like more traffic lights, and then the working conditions, and obviously my kid was 2 years by then, and all these things played into it. And I actually I like the generalism bit in ED. Like, okay, uh, you don't know which part of the body, what the
You
complaint
do know
is,
what's
what
coming through
it
the door. Yeah.
do exactly. And then the generalism in GP, although a little bit it's less acute, less emergency type, kind of appealed to me as well. Okay, and then um, well, obviously didn't realize how the life going to be after GP, but I
No.
thought, okay, work-life balance is better in GP, and then that's why I jumped the ship.
Okay. And was there an attraction at all for the continuity aspect of general practice?
Well,
Did
that's
that
the other thing, and I was fortunate to have a GP placement in my first year, like with ST1. I was fascinated by the continuity. Like you can see blood results 10 years back, 15 years back, whereas in hospital, everything was paper. Well, I guess still it is paper at the time. It is paper, I guess, but it was certainly paper at the time. So we don't know the full sort of holistic picture. Whereas here, like everything is there, your drugs and this is obviously system one, and it was really interesting. And you build on it because I think 10 minutes, as you know, is never sufficient, but you build over days and months. You get to know the patient, and then it becomes easy for you. And I like that bit as well.
It's funny, isn't it? Because it's no, no. You saying that. I think that I remember. I can remember as a medical student in Tooting. I remember going to see my GP with my about my asthma, and and I must have been about a third, fourth year medical student by then. And he said to me, I tell you what, we'll try this new inhaler. Why don't you and come back in 2 weeks and we'll see how it goes. And I just thought, wow, you can do that. I didn't know you could use that tool of getting someone to come back and see you again. Just that phrase, that so, and having worked in hospital medicine, yes. Whereas it was just a totally different approach, and I just found that very exciting. Sorry, this is not about me; it's about you. But I just thought
No,
I
no, no.
meant to.
Absolutely. People don't, people just undervalue that bit because in general practice, everything is weeks. We come
Yeah,
back in 3, 4 weeks, absorb the risk, we know the
yeah.
patient, we got information in there. But if you say that to hospital, oh, 2 weeks, it's going to be okay. Well, it's going to be okay. By the time they get the medicine, they start it 3-4 weeks, it's easy.
Yeah.
And then, yeah, and the continuity, the ability to follow up. And then every time, yeah, say for example, you get a letter, you get a result, you have an opportunity to go back. Oh yeah, I know this man. Oh yeah, this happened. Oh, I referred him. This is the letter, and then all this sort of continuity strings in your brain as well. And then sort of you can, when you see him next time, I can see you've been seen with that guy. So is everything going okay? And then that sort of builds the rapport as well.
Yeah, yeah. It's almost like we're given a time machine, isn't it? It's almost like we're traveling time doctors. In fact, it's probably a TV series. Maybe no one else has done that. Who knows?
Absolutely. And if you look at it, I've seen many patients, they go to outpatients, spend half an hour with each whatever specialty, and they come back and see me in 10 minutes when I explain it. Oh, doctor, you spent quite a lot of time with me. Nobody told me this. And they stay days in hospital. No one tells me exactly what happened, what's been done, and what will happen in future.
Yes.
And when we tell them in 3 minutes, no one told me this, doctor. That's the kind of 10-15 minutes, and they say, "Oh, this is the first time ever I've spent so much time with the doctor."
Yes, it is. Surgeons operate, but GPs communicate. It's that extra nuance, isn't it, that we get in general practice that makes the job so much more so enjoyable. We certainly like, but we both like that aspect of general practice. So you started and you did your training. Was it in Nottinghamshire? Was it
in East Midlands? Yes,
in
Nottinghamshire, Mansfield. Yes.
Lovely. And then you qualified. And then when you qualified, what role did you then start doing?
Well, I think obviously, as you know, where during the VTS, the GP training, you have your seniors, you passed out, and then you talk to them, and then they sort of the trend at the time was to locum around in practices. So I was actually quite enthusiastic, able to travel. I was living close to motorway, like I was like 20-mile radius.
Wow.
I was going and then doing, and then there was actually a time where I learned EMIS web on the day, how to work on EMIS web, and then did on call in the same surgery.
Good
I was
grief.
fascinating, and like that made me like my brain was in a sort of top gear because I learned something new, and then the on call, that's fine, I can deal with it. And I was like, interesting. And I mean, that was the idea, isn't it? Like you locum around, get to know patients before, get to know the population, surgery, how it works, and then before taking up a partnership or maybe salaried role and etc. So that's what I did for pretty much 2014.
Wow.
All of 2014. I think by September I attended an interview for a partnership to start in January 2015, and then I was offered by October because somebody gave notice for them. They wanted someone to start in January, 3 months notice. Yeah, and I was still continuing locuming at the time.
So in a way, I suppose the locuming gave you an opportunity to circle around and around to see where the best place to land was, and it sounded like that place came up.
Indeed, and then it just gives you confidence, like working in different areas. Just being a locum, I kind of involved in a couple of QIP products and surgeries. Like people were actioning HbA1cs, okay, satisfactory when patient didn't have any diabetes diagnosis. 50 HbA1c, for example, means he needs diagnosis and treatment, but no one was looking at it, and those kind of. So
that second pair of eyes, almost.
Almost, yeah, exactly. And then TSHs were missed, and so I did an audit in a couple of surgeries on the results, and then they were really pleased with it. So
that's good.
Yeah, it gives you confidence as well. It just makes you understand how different GP surgeries work, and that's the beauty of general practice in a way, isn't it?
So that's interesting. As a GP locum, you had the confidence when you were working in a practice to take on board a project that was quality improvement activity and do audits together. That must have been very impressive.
Well, yeah. I mean, if you you can always. I always have the idea of solution minded. Like you can say there is a problem, but what are the solutions you're offering for that? And I said to this practice manager and I offered, I'm happy to do an audit. And she said, okay, let me speak to partners and come back. And me and the practice manager, excuse me, did the audit. Obviously, she was helping me, but I was the clinical bit, and then we produced it, and then she stored it somewhere. It was nice and easy. So
And so you've had you qualified in India, worked in India for a few years. You've came and worked in hospitals in the Midlands, did your GP training, qualified in 2013, did a bit of locuming around. It sounds like you were part of a real community there with BAPIO, and there was support, and it sounded like a great time to be connecting with people and being supported. What we haven't talked about yet is that you are currently also Vice Chair for Nottingham Local Medical Committee and also Chair of the BMA East Midlands Regional Council. So tell us how you got from what you've just been talking about, starting in your partnership, to now being heavily involved with the BMA and local LMCs.
look, I think that's all started during my GP training. Again,
Right.
any sort of, as I said before, the activism starts with one thing. So I started my predecessor in the local junior doctors committee. He was the chair of the local junior doctors committee. We were both in same VTS, same hospital, in same medicine. I think he was a year above, and then we worked on some rota issue, how the number of hours. There was this thing about monitoring was there at the time. Like you
Okay.
need to, as a junior doctor, you need to sort of clock in how many hours you're working.
I remember, yes.
Yeah. So, and then I started attending the local junior doctors. Then now they call resident doctors JDC meetings, and
Yes.
then I got involved with the BMA. And then I got to know through that, like there is also LMC. So I joined LMC as a trainee rep
Ah.
in 2011, and then I was already active in BMA, and then obviously the journey sort of continued after qualifying.
So people listening to this podcast, we may well have some resident junior doctors, we might have some GPs in training, some newly qualified GPs who might not know too much at the moment about local medical committees. And obviously you're a vice chair. So it'd be really interesting to know what sort of your day job is at the LMC, what sort of functions you perform, but all and what of those would encourage people to then sign up and join the LMC and maybe get active as well?
Look, I think local medical committees, they've been in existence since I think 1910, maybe 1920, something like that. So
Wow.
basically, every LMC, every area has a local LMC. For example, there's a Derbyshire, Lincolnshire, Leicestershire, and Nottinghamshire LMCs in East Midlands, for example. And all surgeries play some levies. Some are statutory, some are voluntary. Certain like pence per patient into LMCs. So the LMCs support locally with the sort of enhanced services contract, for example, or contract issues and anything to support the partners and the GP community as a whole. And they do a brilliant job because by the nature of the work, GPs are independent contractors, are independent businesses. So there are lots of things like they help with partnership disputes, for example, staff issues, premises. There's always the work going on, as well as they represent GP community to commissioners, any sort of local arrangements. They're in sort of discussions about everything. And obviously, more lately, primary secondary care interface. All LMCs are obviously playing a vital role in terms
Yeah.
of gathering the GP collective, so to speak, GP ideas, and then representing to the commissioners or secondary care. And the work is obviously ongoing. And so that is the role of LMCs. But as in networking, it provides you sort of great network yourself. A lot of LMCs welcome trainee representatives, often, obviously, understandably, as a trainee, you got your portfolio, your exams, your work, your obviously family, and etc. So, but that gives you opportunities, and then you get to know the committee members, the areas and jobs and people. When I joined at the time, we used to have open meetings. I used to meet a lot of GPs, and you can have sort of one-to-one advice. Say, for example, before partnership, a lot of GPs in the LMC, to be honest, supported me, and they gave me reassurance. Okay, and then I took it upon. So it is quite an interesting role, and obviously some LMCs have sessional support. For example, I lead still on Nottinghamshire LMC from a locum and sessional lead for the LMC. So what we do, again, like general practice, every LMC is different. They have their own way of action working. So we have committee members elected in 3 areas: South North, City, and Mid North. About 20 people, and then Basatla as well. Sorry, about 20 committee members, and within that, people elect a chair, a vice chair, a treasurer, and a couple of board members. So the board looks after the day-to-day running of the LMC behind it, but the committee discusses about the ongoing GP issues, everything and anything. And within the committee, certain people look at the moment working on different areas of general practice. So every 3 years, the committee gets elected. When right at the beginning, when the new committee is elected, we set up a strategy for next 3 years, and everyone is allocated. There are different people sort of working on different strategies, areas for the 3-year period, and then we just keep the work going.
So that's quite a healthy turnover, isn't it? Good 3 years, fresh people, fresh ideas, keeps people motivated. I guess also that requires again a lot of listening, doesn't it? As an LMC, there must be quite a close connection between you as a body with the jobbing GPs in the area, partner, salaried, locum, everyone. Do they need to be feeding back to you what issues are, so you can support?
Yes, obviously that's a big challenge.
Yeah, I bet.
And you can never obviously say that, oh, I have cracked it. I'm 100% I'm done it. So it's an ongoing process. Obviously, before pandemic, we used to have PLTs and any sort of education events, talk to people. Those were there. Yeah. But after pandemic, different ways of working. For example, Nottinghamshire LMC, we have a weekly briefing to the practices. It's a recurring invite on Monday lunchtime. Obviously, not everyone can make every Monday, but you can just sign into it. There are some updates. We present the liaison team. So we advertise, like, for example, next Monday, this is going to be discussed. If you're interested, you can tune in. So that kind of thing. And yeah, I think now we have WhatsApp groups, so it makes a little bit, I wouldn't say easy, less tricky, rather, a little bit less tricky to navigate, because social media is there. Only last year we set up a Nottinghamshire-wide GP group, the LMC has set up, and it's fascinating, the discussions and the interaction we're having there.
I bet that's probably could be quite hard to manage at times as well. I get that there's a lot of...
Yeah, we have a generic LMC mobile number within the group, and then we have a liaison team, we have a liaison manager, and couple of 3 liaison team members. Between them, they manage the group. But there are other things, like, for example, there's a big UK LMC conference coming up next week. I am representing Nottinghamshire, so obviously I posted yesterday, for example, about the agenda and some of the discussions about some of the topics. So what I would say to anyone in listening to is, LMC is a key part of general practice. They are statutory, and then even if you look at the PCN desk contract model, LMCs are mentioned, and every ICB in sort of different way, shape, or form, some sort of way, they just kind of get in touch and listen to LMCs. So it is a big job if you enjoy being the activism bit. And at the moment, I think, well, last year things were slightly different in GP land with the collective action. So it provides a different way of looking at things, and then it makes you understand the problems in day-to-day GP stuff, as well as the wider contractual and medico-political aspect as well.
Yeah. So what I think one very short question, but probably a longer answer to end on would be, I'm really interested to know, with your two roles, your with BAPIO, sort of national organisation, and Nottinghamshire LMC is much more local. What would you say the issues are at the moment for international medical graduates nationally? If you know the answer to that, but also what issues are local sessional GPs in Nottinghamshire facing at the moment? Would you say, is anything that stands out particularly that you're having to work really hard and support members with at the moment, or that people are telling you about?
Yeah, I think international medical graduates, I think they are different set of issues. I think first and foremost, the progression, career support and opportunities is one aspect. The second aspect is regulation. As you can imagine, the GMC data, everything suggests you're more likely to be under the radar and punished being an IMG. And I think overall, like support and then sort of mentorship in a way, like whatever career you're choosing and how you're progressing, and even after you become a consultant, for example, there are always things happening. There are local negotiating committees, LNCs, within each hospital, and that committee looks after all the doctors within the hospital, and then they look at issues facing them. So, and anything they can support, like for example, if something happening within a division, with your contract, sort of mentoring advice and those kind of things. As a GP, the key issue we discussed, like for example, CQC performance issues, if you have any, obviously they can support. But I think from a GP forum point of view, we still we have a good community sort of support online, but we need to sort of work with the local BAPIO divisions and then see how we take this forward. In terms of sessional GPs, I think we have in Nottinghamshire, we have a provider arm called Phoenix program. So they basically, in collaboration with Phoenix program, Nottingham LMC, we are doing some CPD events for locums.
Oh, wow.
So we had one face-to-face event in October. Obviously, we provided BLS teaching. As you can imagine, it's hard to get BLS for some locums, and it was face-to-face. And the common theme was unemployment. And rather underemployment. Yeah. Like people were forced to reduce sessions. I think it's a toxic paradox at the moment. Not many people outside GP understand it, because I think one aspect we're saying we need more GPs. The other end we're saying, oh, GPs are training to become bus drivers. That is not good at all.
Yeah. It reminds me of a quote from Amartya Sen. I think he won the Nobel Prize anyway, when he described that he established that famine is not caused by lack of food, it's caused by lack of distribution. There's a definite need and there's a definite supply. We're just not matching the two. And you get these areas of high deprivation of GPs and areas where there's oversupply, and we're just not managing to connect them.
Absolutely. And as you say, that's a very good quote, actually, lack of distribution, I guess. I think PCN contract, the PCN, there's the current model where there's arts funding, funding for additional rows reimbursement scheme, funding through that kind of create a vacuum. And then post-pandemic, there are a lot of other challenges for practices as well, like energy costs have gone up 1 year, and then every year the inflation, pay raises, and their income actually not keeping up to date. I guess I think you can talk about it for a whole podcast.
Yes.
That's one. The other common theme I observe for local sessional colleagues is like they've been asked to supervise other allied health professionals and not been given enough time, as you can imagine. There is that bit of risk absorbing, isn't it? Because there was a JMC case where a registrar in ED was penalized, not examining a patient seen by a PA, I think. So that kind of, when these things come up, people don't know when you're advising someone, are you supposed to go and examine them
Yes.
and then do everything in detail?
There
So
are all
those
these
kind of
unknowns, aren't there? And these sort of
Yeah.
almost like these little traps have appeared. Yeah. Lovely, Kalindi. We're recording this on the 1st of May 2025. It's going to be the hottest 1st of May on record, apparently. We've got a bank holiday weekend coming up, Kalindi. What do you hope to be doing this weekend?
I think as part of my portfolio, I do some out of hours because I think it complements my role. So I'm working a session on Saturday, but Sunday I think just chilling out. We 4 families live close together, so we are planning to go out for an adult-only dinner, leaving kids at home.
Oh, lovely! Because your kid, but you mentioned must be about 13 years old.
Oh,
now?
16 and 12 now.
16
Well, they can stay at home
Absolute.
themselves.
Yeah.
Obviously, we make arrangements, food and everything, and we have same age kids as well. So we thought, okay, we'll just go. And another thing is, my oldest is in year 12, and some kids are doing exams for A levels. Some other family kids, so they're all staying at home, preparing for exams where we go out. So that's the plan, and nothing really. Just wind down Monday, get ready for Tuesday.
That all sounds lovely. A nice, relaxing, winding down weekend with a lovely big meal out with adults. That sounds pretty perfect to me. Well, Kalindi, thank you so much for coming for this conversation this morning. It's been really nice talking to you, and I hope I've managed to enthuse our listeners about and hopefully some inform as well about the wonderful work that BAPIO does, but also about you and Nottinghamshire LMCs. I've been up to Nottinghamshire LMC a few times and given some talks. It's a lovely, welcoming team of people. I've always been made to feel very welcome in Nottingham, and it's been lovely to see how much support you as an LMC give to your local sessional GPs. And we've got our own members in the area, and we've got lots of feedback again. So it's really great to meet you again and talk to you and all the wonderful work you do. So thank you very much. Have a wonderful weekend. I hope you're not too busy on Saturday, but enjoy your meal. And Kalindi, I hope we speak again soon.
Thank you very much. And it's been a pleasure coming to the podcast. And thanks again for having me.
Great.
You have a good rest of your day and weekend as well, Richard. Thank you.
You too. Thank you.
Bye-bye.
Bye-bye.